In this episode, you will learn
common health challenges in migrant populations and how to address them,
how to navigate interactions with immigration enforcement in your ED,
practical steps for protecting patient rights while providing excellent patient care,
and some ways to advocate for and support our patients who are facing immigration challenges. Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Julia Magana
and Sarah Medeiros. Welcome back to EM Pulse. This is the second episode in our special mini-series on advocacy with Dr. Anna Yap. In today's challenging healthcare landscape, we as emergency physicians are on the front lines of caring for some of our most vulnerable patients. And today, we're going to dive into the critical world of immigration health and undocumented patients, a conversation that's never been more timely or important.
I'm Dr. Anna Yap, your guest host for the special EM Pulse mini-series on advocacy in medicine. Our guest today is our own UC Davis Health Policy Fellow, Dr. Shank, an emergency physician who will be joining us as faculty next year and who has spent her fellowship focusing on migrant populations and working with the UC Davis Human Rights Initiative, a group that partners physicians with local immigration lawyers to complete forensic medical examinations that bolster asylum cases. As we navigate an increasingly complex immigration environment, emergency physicians need to be equipped with not just medical knowledge, but also a nuanced understanding of the unique challenges facing undocumented patients, asylum seekers, and refugees.
So, Anna, as we look at recent data, about 1 in 20 California residents are undocumented immigrants, making it highly likely that we as emergency physicians will regularly care for these patients. But being an effective emergency physician means more than just providing medical care. It means being an informed advocate for our patients. And in these uncertain times, with rapidly changing policies and heightened enforcement activities, we need to stay educated about current events and policy changes that affect our patients' access to care and their willingness to seek it.
Right. Whether it's understanding recent changes to immigration enforcement in healthcare settings, knowing our rights and responsibilities when interacting with law enforcement, or being aware of evolving state healthcare policies, this knowledge directly impacts our ability to provide safe, ethical, and effective care. Today's discussion will help you navigate these complex waters and advocate for your patients during what may be their most vulnerable moments.
So welcome, Ellen, and thank you for being here with us. Can you help our listeners understand the different categories of patients that we are talking about today? Undocumented patients, refugees, asylum seekers, what exactly are we talking about?
Yeah, definitely. I think it's a great thing to start out with some basic vocabulary when we're talking about this issue. So refugees are essentially individuals who are granted protection before entering the United States. So they're coming from countries where they cannot return to their home country because of persecution, they're fleeing violence. And accepting countries will actually provide them with resources once they arrive at their destination country. So those are refugees. Then we have migrants. So migrants are essentially folks who move around between countries and across borders, usually for labor purposes, and they're not fleeing any particular persecution. Immigrants go through a really long and onerous process to secure a level of citizenship or a green card, and they are free to go back to their home country if they so choose. Asylum seekers, which will be the biggest focus of today's discussion, are people who are fleeing persecution who have to request protection after already arriving at their destination country. So the onus to prove their persecution status and try to secure basically what refugees already have, that protected status, the onus is on them to prove that.
So why do these populations even matter to emergency physicians?
So emergency medicine docs are really highly likely to interact with these patients, as Sarah alluded to earlier. So if we say about 5% of California residents are undocumented immigrants, in California, there are about 200,000 pending asylum cases. So that's approximately 1 in 10 of undocumented folks. So if you maybe generously see 20 patients per shift, the likelihood of caring for an asylum seeker is about 1 in 10 shifts. So that's someone who has an active asylum case, is not just waiting for an appointment to happen. So these folks also face a ton of barriers when they seek emergency care, and it's really important to have your spidey senses activated when treating this particular population.
Yeah, talk to me about some of those barriers.
The main barrier right now in particular is the fear of deportation. This will often translate to a delay in care, not wanting to be labeled a public charge, which is an antiquated concept, but a real concern for folks who maybe don't want to sign on for public benefits in the case that in the future, their name on a specific registry will lead to them being targeted for deportation. So there's the fear of deportation. There are also cost concerns, language barriers, a lot of other barriers that are more common to the immigration population at large.
What are emergency physicians' obligations under EMTALA taking care of these sort of patients?
It's pretty much like any other patient, right? EMTALA doesn't specify who shows up to your emergency department. It says that anyone who shows up to the ED requires an emergency medical screening and stabilization. Doesn't matter what their immigration status is. So you can remember that patient confidentiality definitely applies regardless of immigration status, and your ethical obligations are just the same as any other patient under your charge. We don't ask about citizenship status when somebody walks through the door. It just isn't that often relevant to emergency medical care.
So, Ellen, when you're taking care of patients in the ED, how do you know if a patient that you are going to see might fit one of these categories? And does it change the way that you approach the interaction?
Yeah, so most of the time you walk into a patient's room, you're not going to know their immigration status before you stop talking to them. Often by the end of the interview, you likely won't know their immigration status either. So the approach is nothing incredibly groundbreaking, but there are a couple things to keep in mind. Of course, with any patient who doesn't speak English as a first language, please use an appropriate language interpreter and respect their wishes if they do prefer a family member to translate, if that's more culturally appropriate for them, and if that family member is capable of doing so. In particular, when caring for folks who have made a long journey to travel up to cross the U.S. border, and this is a little bit more relevant to states that are border states, it's important to ask a thorough past medical history and ask about their last healthcare visit. It's very possible that they made a lengthy journey to cross the border and come into the United States, and they may have either never had a medical evaluation before or potentially missed a lot of longitudinal care and may have a lot of chronic health needs that need to be addressed. If it's a pediatric patient, you should consider missed routine vaccinations. Also, consider trafficking and unaccompanied minors. So, in particular, along the Mexicali border, when unaccompanied minors come to the United States, they're often brought up by coyotes or paid smugglers. And these individuals, sometimes in attempts to get remuneration for their services, will sell the child into forced labor or sex trafficking. So it's definitely something you want to keep an eye out for. You should also consider screening for communicable diseases, TB, HIV, Hep B, Hep C, especially if they spent some time in a detention center or a shelter in a border city before crossing. They have similar risk profiles for incarcerated individuals for these communicable diseases, in particular, latent TB.
What type of special medical considerations should we keep in mind when taking care of these migrant populations?
Treating chronic conditions due to a lack of regular care is going to be really big, particularly if they have freshly arrived in the United States. These individuals are also at higher likelihood of being diagnosed with PTSD, depression, anxiety. These are very, very common in this population just because they have disproportionately high histories of trauma, persecution, and different stressors. If they made the journey by crossing the border wall, there's also a higher rate of orthopedic injuries from crossing the border wall, and we talk about that in a bit as well. They have higher rates of infectious diseases. It can. From a GU and GYN perspective, there's a high rate of sexual violence along the journey up, in particular from the Mexicali border, and you should consider pregnancy, STIs, UTIs, and sequelae of sexual violence.
So this is a lot, and especially when there are language barriers and cultural barriers. How can we create a safe and supportive environment for patients who might fear seeking medical care in the first place?
Yeah, so I think a big thing it sounds like a little thing, but it's actually a big thing. But if your institution permits, posting signage indicating that the ED is safe for all comers, regardless of immigration status, that's big. And having that available in multiple languages so people can understand that is also important. Like we touched on earlier, using professional interpreters rather than family members if possible, but then also respecting patients' autonomy if they would prefer a family member translate for them. That would be part of that trauma-informed care piece, just to make sure that we're getting a good history. We should also, again, avoid asking directly about immigration status unless it's medically necessary, which I would say it rarely ever is. And then also create private spaces for sensitive conversations. So these are not conversations that should happen in the waiting room, in a curtained off room, something that should have four walls around this conversation. And then be aware that some of their symptoms may be manifestations of past trauma. So 87% of torture survivors who resettle in different countries suffer from chronic pain. So it's something that's important to be aware of. And if you notice physical manifestations of torture or suspected non-accidental trauma, that's something that should be high on your differential.
So I know over this past year, you've been volunteering with the Human Rights Initiative and been doing asylum evaluations, which sounds really cool as an emergency physician. What does that actually entail?
A forensic medical evaluation is basically the term for where we speak with an individual who has already started the process of undergoing an asylum court case with an attorney. And so a forensic medical evaluation will happen when the attorney refers the patient to a medical team. So the medical evaluation usually takes about 3 to 4 hours, requires a dedicated interpreter, and it's essentially getting an incredibly deep social determinants of health history, including childhood, education. You'll go into subcategories of traumatic experiences and ask a lot of yes or no questions. A lot of this will actually be spelled out in their official declaration that they develop with their attorney. So you want to cross-reference this in your final affidavit that you'll produce. And you'll also do a very thorough physical examination, documenting photos with a forensic ruler to include in the affidavit of anything that the patient endorses is a sequela of their trauma. And you, as an evaluator, will take the affidavit and the history, the physical exam, and decide whether it is consistent with the story that you're hearing.
Ellen, a lot is changing right now. Are there any specific policy changes that we need to be aware of for immigrant populations?
Oh my goodness, Sarah, it is a crazy landscape right now. By the time this comes out, I'm sure the answer to this question will be very different. But I guess a couple things I want to highlight where we recently were. So first, we had Title 42 during the COVID era, which was essentially a World War II Emergency Health Authorization Act that disallowed people who were carrying tropical diseases who were in distant countries during World War II to enter the United States for the protection of U.S. citizens. This was enacted during the COVID era to protect U.S. citizens from this hypothetical menace of folks carrying COVID across the border. Title 42 was used around 2.5 million times to reject people's claims for asylum during the COVID era. More recently, in May of 2023, Title 8 replaced Title 42. So this was almost back to business as usual with a couple important exceptions. So the new rules were that migrants could not enter between ports of entry, essentially enter into the United States illegally and claim asylum on U.S. grounds. So that is actually against common international refugee guidelines. It also disallowed people, if they were rejected for their claim of asylum, it disallowed them to come back into the United States or attempt an asylum case again within the following 5 years. And if they tried to get into the United States between ports of entry after that, during those 5 years, they could actually face criminal charges. This also required people to apply for asylum in every single country that they pass through on their way to the U.S. So if somebody's coming from Colombia, they have to apply for asylum in Panama and Costa Rica and every single country, which is incredibly uncommon. So those are some of the policy changes that we saw. However, it did have the saving grace of actually having a method of applying for asylum. There was the CBP One, or the Customs and Border Patrol One app, that was used where people would refresh every day while they're sitting in these shelters, usually in Tijuana, along these border cities, awaiting an opening for an asylum case. For about 280,000 people waiting every day, there were about 1,000 cases that were accepted per day. So incredibly uncommon to actually receive an asylum court case, but at least there was a method. Unfortunately, as of just a couple weeks ago, CBP-1 was inactivated. So right now, we have no way for people to request asylum, even if they're waiting at a border city such as Tijuana. And so right now, we have hundreds of thousands of people in limbo, not really sure what's going to happen next. So that's a big policy change. We also heard about this a little bit earlier when we were talking about increased risk for orthopedic injuries. About 200 miles of the border wall height along the southern border was increased from 2018 to 2019 from 10 feet to 30 feet. And we've seen a huge spike in orthopedic injuries at border health clinics and at level 1 trauma centers along the southern border. Most of these people are not weight-bearing when they leave the hospital, and about 80% of these people have no way to access follow-up orthopedic care. So it increases the morbidity of folks who would otherwise be able to contribute to the workforce, and it's an incredibly difficult problem.
So, wow, it's been a lot of policy changes. I know this is a really uncertain time, and I know a question that's been the top of our minds is we've been hearing a lot about the possibility of having immigrations and customs enforcement come to our hospitals, come to our emergency rooms. And I think a lot of us aren't really sure what to do if ICE shows up in our emergency department.
Yeah, you're right. So it's a scary situation. There's a lot of unknowns. And I just want to give the caveat that things are changing very rapidly. A lot of institutions will have very specific protocols. And this isn't meant to provide legal counsel, but they're general guidelines collected from different institutions that are doing really good work in this space. So as a little bit of background, the primary agency for immigration enforcement in the U.S. is Immigration and Customs Enforcement. We've been talking about them as ICE so far, and this is a component of the Department of Homeland Security, or DHS. ICE enforcement at hospitals was historically very rare, but unfortunately, policy has changed very recently as of January 2025. Basic things that an emergency physician should do if ICE shows up at your doorstep. Stay calm. Do not try to physically obstruct ICE agents, and stress the need to follow institutional protocol. So because this is so cloudy and a nebulous legal area, you're going to need legal backup and authorization before they're allowed to enter into non-public areas of the hospital. And you can tell them this. Locked areas that require usually a key card or a badge to enter, are not public areas. And you can indicate your need to return to patient care as soon as possible and request that they wait in a public area outside of the hospital or in a public area of the hospital.
So to clarify, public areas in the hospital are like waiting rooms, lobbies, places where the public can go to. But patient care areas, places with key badges, those are all places that are non-public areas and therefore they're not allowed in.
Correct. And that's actually not a huge change in policy. That has been allowed for a long time. So anyone can enter a public area of the hospital, but immigration, customs enforcement, law enforcement are not allowed to come into locked areas of the hospital or non-public clinical care areas without something that's known as a judicial warrant. So even if an ICE agent were to offer you a document that looks quite legal and intimidating, you can just let them know that, hey, I understand that you have this paperwork for me, but I actually still have to get legal backup because I don't really know the difference between an administrative warrant versus a judicial warrant, and I'm going to have to get legal backup on this. So I think the really important thing is in these situations is to pump the brakes, to recognize that no intervention by immigration and customs enforcement is as urgent as providing direct patient care to your other patients that you have responsibilities for in the emergency department. So pumping the brakes, saying, hey, I'm going to call legal counsel. Do indeed call legal counsel and your designated hospital liaison, and then have them wait in a public area.
And we'll have more resources and links you can look at in our show notes afterwards. We know that ASAP has released some good guidance on this, so you can take a look there.
And your ED and hospital are probably developing their own policies, so check at home as well.
Yeah, so usually your hospital will have a chief operating officer, medical director of the day, who you can call and reference, just like you would if you had any other really complex patient care question. And I would say if you have legal counsel available, save that number on your phone. I did that the first day that this came out. I made sure to have that readily available in the case that it's needed.
So how do you approach, documenting immigration status in medical records? I'm sort of concerned about actually putting that down in writing.
Yeah, generally, I would say avoid asking about immigration status altogether. It's unlikely that your medical records will get pulled for use against a patient in a court, but it's not impossible. The question alone of asking about immigration and immigration status, unfortunately, that starts to construct a barrier between the patient and physician relationship, and it makes undocumented patients understandably much more wary of seeking care. So unfortunately, there are two exceptions. So in both Florida and Texas, hospitals are required to ask patients about their citizenship status. And patients are allowed to say, yes, I'm a citizen, no, I'm not, or I decline to answer. But this still puts an unnecessary barrier up between you and the patient. So I would say, in general, avoid asking about immigration status altogether, unless the patient volunteers it by themselves. And in that case, it would give you more of a license to provide them with resources after the fact, but I would still avoid putting it in the EHR.
So let's say you find out that a patient is undocumented. Are you required to report their documentation status?
No, definitely not. And I would, again, avoid putting that in the electronic medical record, but that gives an opportunity to help out in different ways.
So for listeners and, our colleagues who want to support this work, what are some really practical ways that they can get involved?
Oh, my gosh, there are so many ways. You can consider volunteering directly with an asylum initiative. So there are quite a few academic institution adjacent clinics. You can actually look for them on Physicians for Human Rights affiliate website. For example, UC Davis has a human rights initiative, UCSF, Oakland. A lot of these places have dedicated initiatives to help out asylum seekers. You can also join organizations like Physicians for Human Rights, which essentially puts out a lot of updates on policy changes related to refugee and immigrant populations. Also, practically, if you recognize a patient who you suspect is undocumented or who confirms that to you, even if you don't ask them, you can provide a Know Your Rights red card. So these were developed by the Immigrant Legal Resource Center, or the ILRC, and you can actually hand it to them with their discharge paperwork. I've done this a couple times, and I just essentially Google Know Your Rights red card, and I print that out and I provide it to them. And it's a card in a bunch of different languages where they can actually just slip it under their door if they're approached by ICE in their living space, which essentially gives them more information about their rights when interacting with ICE officers. You can also refer individuals that you know potentially have a case for asylum, so who have suffered persecution, physical violence. You can refer them to a local immigration law center or law clinic. You can also participate in an asylum evaluation training course offered by the Asylum Medical Training Initiative. It's free. It's 8 hours, so it's pretty long. It's not CME accredited, but it's updated per the Istanbul Protocol 2022. And it will give you a lot of information for how to perform a forensic medical evaluation. And then I would say, lastly, if you're in leadership, if you're in the C-suite, please support hospital policies that protect patient privacy and distribute information for how other providers can adequately handle this situation if ICE shows up at their doorstep.
So we talked about what you can do in a leadership role potentially. What should our departments or our hospitals or institutions actually be doing to address this?
Yeah, so from top down, you can establish clear department policies and protocols. So designate a specific hospital liaison that people can turn to if they have these questions. You can create written protocols for how staff should respond. And then you can train staff on privacy rights according to HIPAA requirements, because that's the best information we have available to us as of now. You can also provide staff training and resources, provide trauma-informed care training, cultural competency, ensure that providers have 24/7 access to professional medical interpreters. You can also develop community connections, build relationships with local immigrant advocacy organizations, and have a local immigration law center that you can refer people to if you suspect that they could be eligible for asylum cases. You can also make sure that you have physical spaces that allow for sensitive conversations if and when they do come up. So post multilingual signage about patient rights, designate secure areas that don't have curtains for walls where you can have these conversations, and ensure multiple exit paths if patients feel unsafe.
Thanks so much for sharing this information with us and these things you've learned over the past year. Do you have any last tips and tricks for us?
I would just say, I think it's really important to recognize that we are at a pivotal time in our careers right now. From a justice standpoint, when we're working with these individuals, they're probably the most vulnerable and most confused at this point. Our job as emergency physicians is to care for patients regardless of where they're coming from. As the public safety net of the medical system, a lot of the times it's going to fall to us to provide care for these patients. And that's a huge privilege and also a huge responsibility. So making sure to be up to date on some of the policy changes that are coming down the pipe, even though they're changing all the time, it's going to be really important in order to provide really high quality care for the patients that you serve every day.
I want to thank Dr. Ellen Shank for sharing these practical insights with us. As emergency physicians, we are often the first and sometimes the only point of medical contact for some of these vulnerable patients. And understanding how to better serve our refugee and asylum-seeking and undocumented patients isn't just about medical knowledge. It's about being informed advocates who can provide safe, ethical care in really challenging times.
The landscape of immigration policy and healthcare access is constantly evolving, and oftentimes we're finding that our role as physicians are needing to extend beyond the clinical encounter. Whether it's speaking up for patient rights, creating more inclusive emergency departments, or getting involved with organizations doing this vital work, each of us has the power to make a difference. Remember, advocacy starts with staying informed and extends to every patient interaction we have.
So if you're interested in learning more, we will put links in the show notes to resources that we mentioned today, including information about the UC Davis Human Rights Initiative and guidelines from ACEP on how to navigate immigration enforcement in the emergency department.
As always, the views expressed in this podcast are our own and don't represent those of UC Davis.
I want to thank our department for advocating for refugees and asylum seekers.
And of course, thank you to OM Productions for helping us share this important message.
So until next time, stay curious, stay informed, and stay tuned.